So really, about research in medicine, how to critically appraise papers. My major exposure to like appraising papers was like last year, although I've done some audits, quality improvement project. If you work in the United Kingdom, like you're supposed to do like an audit, quality improvement project, sort of like a mini research sort of. But this particular one, how to critically appraise papers, was last year. So during my first year in internal medicine training. So we usually have like compulsory teachings we go for. So this one, like we just went, it was saying, oh, how to appraise papers. And the lady, like she's a doctor, is a consultant, I think in renal medicine, and always small groups of all trainees also from, other parts of the region. And we were divided in small groups. Like she just gave us the paper that day, like I think almost 2 or 3 different papers. And she was, okay, today we're going to appraise this paper. And she just started, okay, so what do you think? Like no one could escape it. And even though it was a very, very brief session, but after that, then I just thought that, okay, this is an area like where we need to be familiar with, because like, number one, to improve even on our practice. Number two, to be able to, when we see any paper, to be able to read it and say, okay, what are the things I should actually look out for and how do I interpret this paper? Yeah. So the team will be researching medicine, how to critically appraise papers. So the table of content, we've done the pre-discussion questions. We're going through what is critical appraisal, why should we critically appraise, the main types of literature, how to appraise, and then we'll talk about the paper to be appraised. Yeah, we've done the pre-discussion questions already. So what is critical appraisal really? So when we hear critical appraisal, it is more than just reading and summarizing the paper. Basically, it involves like to weigh up evidence critically. You want to weigh up evidence and assess the validity, that's the closeness to the truth, and the usefulness, that's the applicability. It is also the process of carefully and systematically examining research. You want to judge how trustworthy it is, the value and the relevance in a particular context. That's what it involves. Also, it's like a balanced assessment of the benefit and strength of a research against its flaws and weaknesses. So when you take a paper, you want to look at what are the things that have been highlighted, that the strengths, and what are the weaknesses, what are the things that can be improved upon. So it involves assessing the research process and results, and it is a skill that needs to be practiced by all health professionals. Not only if you're saying, oh, I'm in research, or maybe I'm pursuing a doctorate degree or something, but it's a skill that needs to be practiced. So why should we critically appraise? The first one, to find out the validity of the study. Are the methods robust? Is that the right method that should have been applied? To find out how reliable the study is. What are the results? Are they credible, or are they just scooped up figures or something like that? And also to find out the applicability of the study. Is it applicable to my practice? Is it something I want to include in my practice? And is the study important enough, like, for me to change my practice? So this is just like a summary of the main types of literature we have. So you have the primary, secondary, and tertiary literature. But most times for critical appraisal, you go for the primary literature, that's the original research, or if there's a new scientific discovery. And for the primary literature, like, they can give you immediate result of the research activities, includes the analysis and the data that's been collected. Now, if I'm going too fast, please just type it in the comment section, but just so we can get to the main paper. Yeah. So how to appraise, like if you decide, okay, I want to appraise a paper, I want to practice or something, or I've been asked to appraise a paper. So for instance, like now, it's the COVID-19 pandemic. You can say, okay, so what area of COVID-19 pandemic? Is it the treatment? Is it in terms of respiratory support? Is it in terms of ventilation? You have to identify the question, then search for the literature. There are various resources where you can get the literature from. You have to select the relevant title, then appraise the paper, make a decision, and evaluate it. So the PICO tool I mentioned is very useful for literature research. It's used in evidence-based practice. So basically it stands for, when you're searching for literature, you also identify either the patient or the problem or the population. And then you want to find the intervention. For instance, this paper talking about the use of Remdesivir for the treatment of COVID-19. So the problem basically identified was COVID-19, that's the problem. Now the intervention high, which is high, is Remdesivir, which is what we are looking at. Then comparison control or comparator, that will come into about what was the outcome in the use of Remdesivir in the treatment of COVID-19 from this paper. Then the outcome, did it lead to death, sickness, and reduced mortality and morbidity? So the paper to be appraised, and the topic is Remdesivir for the treatment of COVID-19. And yeah, the final report. It was published in the New England Journal of Medicine, November 5, 2020. And okay, yeah. So just like an introduction about Remdesivir, what it's all about. So it's like a prodrug of nucleotide. It's a viral RNA polymerase inhibitor. It disrupts the production of the viral RNA, which prevents multiplication of the virus. Basically, the way the virus works is that, like, getting into the cell, it releases either the viral RNA to lead to the replication of the virus and all that, which is also where the vaccine comes in this phase. So Remdesivir has it has been found to have in vitro activity against the SARS-CoV-1, which is the COVID-19 virus, and the MERS-CoV. So the MERS stands for the Middle East Respiratory Syndrome virus, basically. Just a quick one. Okay, so the initial questions you might want to ask. So now I'll be going to the, how to appraise the paper, what you want to ask. So the initial questions, you want to look at the paper and say, why was the study done? What were the aims and objectives? What exactly is being tested? Who are the authors? You want to look at what's their experience, their qualification, their background, and who is the study aimed at. So at a glance, the first page of that paper should really give you an idea of what is happening. Going through the front page here, you can already see the background saying, although several therapeutic agents have been evaluated for the treatment of coronavirus, no antiviral agents have yet been shown to be efficacious. So that's already the background. Here, in this line, you can already see the method that has been stated out. In the results, this has been stated at the conclusion. So this is just the first page. This particular paper is a 12-page document, but the front page already gives you an idea of what are they saying, how, what was the methodology, what was the result, and what was the conclusion. Now to go in depth into it, if this particular paper, if you look at it, it said, why was the study done? Basically, it was in a bid to find a therapeutic agent for treatment of COVID-19. With the emergence of the COVID-19 pandemic, several researches have been going on and all that. And one of it was actually the use of Remdesivir. Now, the aims and objective, if you go through the paper, now opening sentence, the first one identifies to determine if it can be, if remdesivir will be an effective treatment for COVID-19. In the opening sentence, it actually said, although several therapeutic agents have been evaluated for the treatment of coronavirus, no antiviral agents have yet been shown to be efficacious. Now, it just like can be interpreted like they were trying to find out if remdesivir can be an effective treatment. The other aims and objective from this particular paper is to determine if the use of remdesivir will result in an earlier time to recovery. If we also look at the first page under methods, that's the last sentence, it stated there that the primary outcome was the time to recovery, defined either by discharge from the hospital, hospitalization, for infection control purposes. So the other aim and objective, so all this is even from the front page, is to determine if it will result in an earlier time to recovery. The third one, if we look at the next page, the first paragraph, under methods, so the line 8 there said, to ascertain if remdesivir will minimize disease severity in COVID-19. So all that, like, those are the aims and objectives that have been identified from this paper. So that just gives you an idea already of what exactly is going on with the paper. Now to go on, you can, just to add, you can just open the paper side by side with this webinar, because most of what I will say is from the paper, so we can easily make reference to it. Yeah. So the other question, the initial question, what is being tested? Like when you take a paper, you really want to know what are they testing? So if you look at it, now also in the front page, under methods, after they mention the methodology, trial of remdesivir in adults hospitalized with COVID-19 and who had the evidence of lower respiratory tract infection. So that is in the second line under methods. There you can see it said, in adults who were hospitalized with COVID-19 and had evidence of the lower respiratory tract infection. So that you can easily identify, oh, that is what is being tested. Now to look at the authors, there's a long list of, if we just check the upper parts of the paper, there's a long list of authors there. One party, and they all have like extensive research, even relating to COVID-19, not just for remdesivir. They also have like extensive researches to their name. But one particular author that was striking. So if you check on that line, you're going to see second to the last line, A Osinosi. So I actually checked that up. So her name is Anu Osinosi. She's in Nigeria. She's the executive director of clinical research at Gilead Sciences. So she's the executive director of clinical research, leading the emerging and respiratory virus group in the virology therapeutic area at Gilead Sciences. And she was also the project team lead for Remdesivir across various indications, including COVID-19. She has over 15 years of experience in infectious diseases, liver disease, global health, and drug development. She's on, not like she's on Twitter, but if you search for her name, it will show you some of her presentation about this particular paper and even about Remdesivir. Yeah. Now that's just talking about the initial question. So that's just like a brief overview. It tells you what you're looking at, what you want to look out for, really. Now going to the main questions, which I would say is like the main theme of critical appraisal. You want to ask like, what type of study is it? Is the design appropriate for the hypothesis? Because you have different study designs, you need to know, was it appropriate in that setting? The study original, or was it like a follow-up on the previous research? And the subject, the recruitment, how did they recruit? Very important. That's what determines if, like the paper, if you're going to accept whatever they say or even consider it Like how did they recruit, who recruited, the inclusion and exclusion criteria is very important. What was the setting, any variables, was the research population, like is that population representative of the general population, any controls and why. So before we go into that, I just want to show different types of like studies that we can have. So here, if the researcher assigned exposure, then it should be an experimental study. This paper was an experimental study. If there was no exposure, then it's just an observational. Now, because this paper is more of an experimental study, I'll just focus on this. The allocation random, yes. So which will make it a randomized control trial. If it's not random, then it's a non-randomized controlled study. Now, particularly for treatment, if you're trying to develop a new drug or a new trial, the best one to go for is randomized control trial, because then you're not saying, oh, by force, this person must have this treatment, or I must give this person this treatment, because then you're just trying to find out, is it going to be effective or not? And these are the other types of observational study. Now, the types of experimental designs that's under the experimental study, I won't bore us too much, but this particular paper is a double-blind randomized control trial. These are the other types of experimental studies you have, but this is I'll just focus on the double-blind studies, which this paper is. Now, this paper is a double-blinded one, so the types of blind, you can have single blind, where only the participants were blinded. That means the participant did not know the intervention or whatever is being given to them. Now, double blind, both the participants and investigators were blinded. That means even the person you're recruiting and even the researchers, they don't know which patient is getting the placebo and which patient is getting the control. This is very important, like to reduce bias. So bias in terms of, oh, maybe because I know this patient, now I'm going to offer this treatment to see if it will work, or maybe this because this patient is male, female, or has these comorbidities, that I'm going to offer him or her this. So both the participants and investigators were blinded. So the randomization is usually done by independent, like party or independent person who is not even part of the research. And we have the triple blind, that's the participants, investigators, and statistician were blinded. That is very difficult if the statistician is even blinded. Of course, and the opposite of a blind trial is an open label trial. So in that, you're just saying, oh, this is Remdesivir, like we're giving it to you. Like, so that one is an open label trial. And with that, there's more risks of having bias rather than the double blind. So a double blind study, they just random assignments of test subjects to the experimental and control groups. It's a very critical part of the double-blind research design. It identifies the subjects and which group they belong to is kept by third party. It is not revealed to the researchers until the study is over. Yeah, which is, it really helps to reduce bias, because if as a doctor or as a part of a research team, then I know, okay, this person is taking Remdesivir and this person is taking the placebo. Now, if I know this person is taking Remdesivir and it's part of my research, I might start having, the inclination to, I'm checking on this patient, or because I'm doing Remdesivir, I'm doing the blood tests, I'm checking regularly, rather than the person taking the placebo. So there's a lot of bias. But if I don't know, I don't know if this is the person that's doing Remdesivir, and I don't know if this is the person that's been giving the placebo, I'm going to act equally to both of them. You're going to treat them equally. You're going to do the same number of follow-ups, rather than if I know this was the person that Remdesivir. So which is yeah, good. So the other main question you want to have, like, is the setting appropriate? Is it like a primary care or secondary care? Is it like in, like for instance, is it like in United Kingdom or abroad? If it's done abroad, now, was the same like quality of inclusion and setting? Did they check all this at all centers? And was study design appropriate? Then if they were biased, how were the bias minimized or avoided? Yeah, so to just go over the answer. So the main question, what type of study? This paper in particular is a double-blinded randomized placebo-controlled trial. And I would say yes, the design was appropriate, and yes, it's an original study. So this paper was from like the original research of introducing Remdesivir to see if it was going to be effective or not. Now for the recruitment, all the points I've highlighted, they're all from the paper. And yeah, so if you look at even the first page under the results, it's already stated that a total of 1,062 patients underwent randomization. Now to talk about the recruitment, yeah, all adults, that's 18 years and above, who were hospitalized with COVID-19 and had evidence of lower respiratory tract infection. And the enrollment period, also from the paper, was from February 21st, 2020 till April 19, 2020. It's very important when you're appraising the paper to know what was the period of study, because if it's just 1 week, 1 month, and if now the author is telling you in the conclusion that, oh, because I've tested this drug for 1 month and I discovered this effect in this person, then you should use it. Then you should think at the back of your mind, so why was it done in 1 month? What if it's done in 2 months, 3 months? Is it going to give the same effect or not? For instance, you know, the paper on the ivermectin and all that, where in fact the sample size originally was so small. And so there's so many things you're supposed to look at, like, yeah, the study period. Now, the recruitment, there were 60 trial sites and 13 sub-sites in the United States. You also, in other countries, there were 8 sites in Denmark, there were 5 sites in the United Kingdom. Particularly, I think that in United Kingdom, London and Manchester, where intensive care units were one of these 5 sites. 4 sites in Greece, 3 sites in Germany, you had in Korea, in Mexico, Spain, Japan, and Singapore. So that's another good thing I identified about this paper, is that they actually went outside just United States or outside maybe United Kingdom, for instance. They included, you know, other race, other ethnic group, just to incorporate diversity and to see, oh, how will this drug act in this COVID-19 positive patient from this region, which is something also very important. For instance, like part of the vaccine trials, they were taking place like simultaneously in several other parts of the world before, you know, they arrived at the conclusion. The eligible patient, they were randomly assigned in a 1-to-1 ratio to receive either Remdesivir or placebo. So from this paper, the initial research was 10 days course of intravenous Remdesivir. The dosage is in the paper. Yeah, and that is the dosage we even still use now. But it's 5 days. We use in the United Kingdom rather than 10 days. And normal saline as placebo. Yeah. And randomization was stratified by the study site. So study site was at the location, or like the country whereby the trial was going on, and the disease severity at enrollment. Now, another good thing is that when you're looking at a paper, if you're looking at the inclusion criteria, they need to state specifically, like if they just say disease severity, it has various like explanation. Someone else can say, oh, it's severe because this patient is in ICU or the patient requires oxygen. So they've actually defined it. Like severe disease was defined as those requiring mechanical ventilation, those requiring supplemental oxygen sat of 94 or lower, tachypnea with respiratory rate of greater or equal to 24 cycles per minute. And the setting for the clinical trial, they were either secondary or tertiary care. You wouldn't expect this type of trial to take place in primary care, because primary care, they don't, like if it's in the UK, primary care would be like maybe GP and they don't admit, they refer to the hospital. So it's either secondary, tertiary care. Secondary care will be like the district general hospital, and of course you have the tertiary care with the very big hospitals. Yeah, and I would say yes, that the research size was representative of the general population, considering the inclusion trials, considering the different countries in which the trial also occurred simultaneously. Yeah. And another thing, yeah, they had written informed consent was obtained from each patient or from patient's legally authorized representative if unable to give consent. This is very important in research, particularly, especially with, even the time they did the study, which it was Remdesivir, it was a very new drug. They've not used it, with COVID-19, and of course, there's so many things that can happen. So yeah, so they got written informed consent. Is very important to let the patient know, okay, we are doing this trial. You're going to be randomized either to this, either to placebo or to the drug. We don't know which one you're going to have, but you have to explain to them, oh, these are the possible side effects that can happen. This is what might happen. They have to know and be ready and say, okay, I agree to taking part in this or not. Yeah. And for controls, I think it was appropriate in this setting. There are some other type of like trials or research that you might not need a control, but for this particular setting, I think it was appropriate, because then how were they going to know if Remdesivir was effective or not? And for bias, yeah, the bias was minimized by even being a double-blind study in the first instance, yeah. And going through the paper, it was specifically stated that trial protocol was approved by the Institutional Review Board at each site and was overseen by an independent data and safety monitoring board. That is very, very important, because if it was not independent, I tell you, there'll be a lot of bias towards who should receive Remdesivir, towards how are we going to monitor, how are we going to follow up, because you might start telling, okay, oh, we have to keep closer on those that are seeking Remdesivir, so that we can easily follow up on our research. So by that being overseen by independent board has actually reduced bias that might have been introduced to a large extent. So just about the main questions you want to ask. So we've done the initial questions, really to just run through what is paper talking about. Then the main question, the methodology, the sample size, any bias, inclusion and exclusion criteria. Because for instance, if before we get to the conclusion, if they say, oh, Remdesivir in the treatment of COVID-19, if the inclusion criteria did not, for instance, cut across several countries, if it was just localized to the United States, then if they now said, oh, you can use Remdesivir for treatment of COVID-19, you might ask the question that, what if it's tried in, for instance, in Asia, Pakistan, will it also be effective? So just be a part of the main questions. Now to go to the results, even though it's a 12-page document, but they've been quite good in actually, if you go through the paper, in sectioning everything. They've talked about the results, the outcome, they talked about the method, so easily you can follow their stream of thoughts, or even the stream of thoughts of the process of the research, which is how, yeah, the paper should also be, it should be easy to follow. So are the results easy to read and follow? Can you apply the results to your practice? The statistics, the sample size, the duration of the follow-up, any dropouts, like any people that dropped out along the way, and did they give reasons for this? Because of course, not everyone who starts a particular trial, some will complete it. And what was the outcome? So I would say, so going through the first question, yeah, I would say the results were explained in details. Like if you read through all the paper, like they actually explain every step of the way. And for the statistics, for the sample size, there's a table on page 1817, more like a flow chart, where it actually listed that 1,114 patients were assessed for eligibility. Now, if you recall, the inclusion criteria was all adults hospitalized with COVID-19 and with evidence of lower respiratory tract infection. That was inclusion criteria. Now, out of this, 1,062 underwent the randomization. There's a small box, it was actually, I think it's in the next one. There's a small box in that table where it actually says 52 were excluded, 28 were ineligible due to meeting exclusion criteria or not meeting inclusion criteria, and 24 were eligible but were not enrolled. So those were the dropout. So out of the 1,062 that were randomized, 541 were assigned to the Remdesivir group and 521 to the placebo group. And the primary analysis, if you, that will be page 1819. There's a lot of like line graphs where they actually looked at the time of recovery of Remdesivir as compared with placebo. Yeah, so it was a stratified log rank test of time to recovery. Basically, the use of the log rank test, basically because they were comparing Remdesivir and the placebo with the time of recovery. So, yeah. And the other analytical tools, also going through the paper, they've actually stated use of gender. They listed the baseline disease severity, age, race, ethnic group, duration of symptoms before randomization, the site location, and presence of coexisting symptoms. Now, under the result explanation, they actually stated that the patients were assessed daily during their hospitalization from day 1 to day 29. For instance, yeah, if there's a drug that is being tried or anything, you have to know for how long was the drug introduced, for how long were the patient monitored. Is very important before you can arrive at a conclusion that, this drug is effective or this drug should be introduced. For this particular paper, yeah, they were assessed daily from day 1 to 29. Now, they also explained, the criteria for the assessment is very important because it's open to several interpretations. If you're saying, the patient was assessed based on what? Is it based on how well they are? Is it based on the bloods or whatever? But this paper, they were assessed daily on an 8 category ordinal scale and the new score. So the new score basically is used, like for instance, it means the national early warning score. They use it, it's used in the United Kingdom. For instance, we say, the patient is using 4, 5, 6. There are several parameters I will show you, which adds up to tell you the higher the score, then the earlier you think you have to see that patient. It means the patient is definitely not well. So this is the 8 category ordinal scale. All this is from the paper also, where they've actually listed category 1, category 2, 3, 4, 5 to 8, based on are they going to be hospitalized even after being positive with COVID-19? What is their baseline status? Are there limitations to activities? Do they need oxygen or are they on home oxygen? Yeah, all that's listed category 1 to 8, and 8 is death. So this part of the scale they use to monitor those patients from day 1 to day 29. Yeah, and this is the new score. So it means national early warning score. So these are the various parameters. So you have the respiratory rate, oxygen saturation, any supplemental oxygen, systolic blood pressure, pulse rate, is the patient alert, or any verbal response and temperature. So you have all this scores here. So depending on what the patient is scoring, for instance, by the time you add it up, the higher the score, for instance, if they tell you, doctor, the patient is using 8 or using 6, even 5, or you know that you have to see this patient on time, then you want to ask, what is this patient using on? Is it the respiratory rate? Is it the oxygen side? So it gives you an idea of what is really going on. And even after you instituted treatment, when they repeat all the parameters and add it up, you want to know, is the new score getting better or not? Yeah, so this the table is also in the paper. more like a flowchart of the enrollment and randomization process that took place. It's also very important, any paper, like you need to be able to follow through, not like they're just like mumbling all the data and information together. You are not really sure, okay, what was done, who were the patients randomized, who were the patients on the placebo group. Now going to the primary outcome. It's also in the paper under the parts, it's stated specifically primary outcome. What they found out was that patients in the Remdesivir group, they had a shorter time to recovery than patients in the placebo group. So median of 10 days for those in the Remdesivir group as compared with 15 days, that's 5 days difference, which is quite significant considering the pressure on resources, available resources, pressure on hospital beds or everything in the hospital, especially with COVID-19 pandemic. So having something that you can give to patient that will lead to shorter time to recovery of 5 days difference, or that was one of the primary outcomes, which is quite significant. Now, it's also in the severe disease stratum, severe disease, which was highlighted by those requiring supplemental oxygen saturation less than 92, tachypnea. The median time to recovery was 11 days as compared with 18 days. So that's also difference of 7 days in those that had Remdesivir compared to those that had placebo. And they also found that the benefit of Remdesivir was larger when given earlier in the illness. Like for instance, if they come to the hospital, they're COVID-19 positive, we give them Remdesivir, that you're going to get more benefits than that. And in addition, that the use of glucocorticoids or hydroxychloroquine still showed efficacy of Remdesivir. That means using glucocorticoids or hydroxychloroquine together with Remdesivir, they found it to give more efficacy. So 9 days of recovery compared to those on placebo 15 days. So which is quite significant. So already looking at the primary outcome already, you can already see that, there's clearly some benefit already from using Remdesivir. There are also some secondary outcome, and they were able, from this paper showed, and with the use of Remdesivir, that patients in Remdesivir group, they had a shorter time to improvement, shorter time to discharge, shorter length of hospital stay, lower incidence of requiring oxygen. All these are like very huge benefits, I would say, because considering the bed pressure, like pressure on hospital bed, pressure on workforce, pressure on available resources, and even pressure on the oxygen required. If there's a drug that you can give and can give all these benefits, it's quite good. Yeah. Among 913 patients receiving oxygen as enrollment from the paper, the Remdesivir group received oxygen for fewer days. In any paper, they should be able to say clearly all the outcomes. So this is when we gave this is what we've identified, and this is what we found out. If it's not clear, then you won't really be able to say clearly, will this drug be beneficial? But even just looking at the primary outcome and secondary outcome with the results and the methodology, at the back of your mind, you can even tell, now if I use Remdesivir for COVID-19 positive patients, are they going to have any benefit on it? Yeah. And in 193 patients requiring NIV or airflow oxygen enrollment, the median duration of use for this intervention was 6 days in both Remdesivir and placebo group. Now, what is stating that for those requiring NIV or airflow oxygen, that's like getting to very severe disease, COVID-19 disease, it was still the same day. So that's use of Remdesivir in those with very severe COVID-19 disease did not change. I'm seeing a question saying what's new score, so I'll just go back. So basically the new score for inside, that's what they're using, like all hospitals in the United Kingdom, to tell you, it's just like vital signs, the way we say vital signs in Nigeria. It's also like It's composed of vital signs. But the thing is that they add it together. So the full meaning stands for National Early Warning Score. So it's a list of parameters that they are added up. And the score, so the higher the score, then the more unwell the patient is. Now, if the respiratory rate is between 12 and 20, that's 0. If the oxygen sat is more than 96, that's 0. No supplemental oxygen, that's still 0. If the systolic, basically, if all the vital signs are within normal range, you should expect a new score of maybe 0 or 1. But even if it's 2, if the patient is just on maybe 2 liters of oxygen when it's a cannula, then you expect it to be like 2. Now, if the patient's saturation like drops suddenly, a patient that's been well, for instance, okay, COVID-19 positive patient that has been saturating in room air between 94 and 95, new score of 1. Suddenly the saturation just drops between less than 91. It's triggering 3 already. And requiring supplemental oxygen, that will go to a 4 or 5. And they say, oh, doctor, this patient is using 6 or 5 or 7. Then you know, oh, what's wrong exactly? You want to look at the parameters. Patients already like tachypnea, which most of the COVID-19 positive patients, they might start having saturation, even 28. And yeah, so that one goes above 3. Oxygen saturation dropping less than 91. So 3 plus 3, that's already 6. Maybe systolic blood pressure is just 90, that's already 3. So that's going to 911, which you will see in actually a lot of COVID-19 positive patients. So the new score, basically they use in United Kingdom, just like it tells you, it adds up all the vital signs and tells you how well or unwell the patient is. And that's what the new score is. And yeah, so safety outcome. Now, because in particular, this paper and also generally when Remdesivir was tried, I think that was the first group of people to actually start it on a large scale. It's important they've actually mentioned the safety outcome because you want to know whatever intervention, there should be some side effect. You can't just say, oh, 100%, there's no side effect, and that means it's false. Even with the vaccine, so many people have had varying reactions to it. Some have not had any significant reaction, while some, I can recall like 2 weeks ago, yeah, a young girl, I think she was 18 years old, fit and well. She was having tachycardia, like heart rate 160 after having the vaccine. I think after 30 minutes after having the vaccine. And yeah, she had to be admitted. So it's very important for whatever the paper to actually state what are the adverse effects that happen and what are their severity. Because to give you an idea, now if we say this drug or this intervention should be used on a wide scale, and if we're saying that, oh, the adverse event is even more than the benefit we think it has, then of course we know we shouldn't go with it. So particularly from this paper, they actually stated that serious adverse event occurred in 131 of the 532 patients in Remdesivir group, and in that which accounted for 24.6%, and in 163 of 516 patients, which accounted for 31.6% in the placebo group. They've also gone further to state that 47 serious respiratory failure adverse events in the Remdesivir group, 8.8%, including acute respiratory failure and need for endotracheal intubation. So that was in 47 of them, that's 8.8%, compared to 18 in the placebo group. So if you still look at the acute respiratory failure or respiratory failure events in those in the Remdesivir group and placebo group, that in the Remdesivir group was way lower than placebo group, which that's 47 to 80. Now, when you look at this, then you want to see, oh, is it that Remdesivir is actually causing more harm than good? Which will take me to this next point where they've stated, especially in the paper, that no deaths were considered by the investigators to be related to the treatment assignment. Usually with any trial or research or any new drug intervention vaccine, if there's any death, they really go through, like, you go through everything. They report it to the coroner, they go through detailed, they might even do, most times they can do postmortem, look at the blood, look at everything. An independent person goes through that to see, was this drug contributory to the death, or did this drug lead to the death of this patient or not? For instance, the other thing, even on the normal day, if a patient is admitted to the hospital and dies within 24 hours, even if you know the cause of death, it's expected to report it to the coroner to see was there any other thing that happened. So at that point, you're looking at when was the patient attended to, when the patient have medication, all this to see did it contribute to the patient death. So here they've actually stated no deaths were considered to be planned. And 41 events were judged to be related to Remdesivir and 47 events to placebo. So with any paper, particularly when it comes to medicine, because definitely the conclusion will be like, oh, you can use this for this treatment, you can use this in this patient, you want to look at it. Have they stated the safety outcomes, the adverse events, or have they just said, oh, there was no effect, which will be very strange, which will make you to think, oh, what's really going on? Are they trying to hide something? Or are they trying to not be truthful? So there's some common non-serious adverse events that have been identified, and it said it occurred in at least 5% of all patients. And the incidence was generally similar in the Remdesivir and placebo group, which is also very important in that they've listed it. I'll answer the questions later. So the common non-serious adverse events included decreased GFR, decreased hemoglobin level, decreased lymphocyte count, respiratory failure, anemia, pyrexia, hypoglycemia, increased blood creatinine and blood glucose level. Most of these adverse effects, you even find them normally in a patient, in COVID-19 positive patient, not even in Remdesivir. So, so that's why it's been listed as not serious adverse events. Now, mortality. The estimate of mortality by day 15 was 6.7%. That's 36 out of 541 Remdesivir group. But if you remember earlier, it stated that no deaths were related to the treatment assignment. So which means this patient listed, they died from other causes, either from COVID-19 disease itself or from COVID-19 with other comorbidities they had, but not from Remdesivir. Now going to the discussion. You need to ask, like, as the author giving critical discussion about bias or the criteria used, the assessment used, as the tables and graphs, have they been explained in straightforward language? These results, have they been critically evaluated? And is the author's conclusion consistent with results of the study? Because some studies or some papers, the conclusion will be that even though this was what we thought will happen, but this didn't happen. It can, yeah, there's some papers like that that will state that way. Then how can this result benefit my patient? Because if you're going through any paper, that should be what is at the back of your mind. Can I apply this to my practice or not? So I would say that there was detailed reports and discussion about the bias, about the criteria used, about the assessment tools and intervention used. The tables were explained actually, but I think, in my own opinion, that the use of other types of graphs, aside the line graph, should have been employed, considering the extent and diversity of the research. Because going through the paper, apart from papers and the line graphs that were used, there were no other charts that were used. And in addition, chart or graphs highlighting the various comorbidities in the Remdesivir and placebo group, I think, should have been included. For instance, the table just showed, they just listed that some of the comorbidities were hypertension, type 2 diabetes. I think, considering the extent and large scale of the research, yeah, if they've also included graphs to say, okay, patient with these comorbidities that had Remdesivir or placebo group, this is how they responded, rather than, you know, the large scale response. Then outcomes in relation to age in both Remdesivir and placebo group would have been beneficial. There were tables which actually stated, oh, this age, this age bracket had placebo, this age bracket had Remdesivir. But if I think it would also have been beneficial, yeah, if they included, you know, cluttered and say, okay, this was the age range in the Remdesivir group that we think had the maybe shortest recovery time, and or those that died, or maybe those that had serious adverse effect. Like for instance, they stated where some had respiratory failure. If they are charted, oh, what were the age group that fell under that age and that range? What comorbidities did they have? I think it would also be nice, in my own opinion. To come to the author's conclusion, now the author, like the papers, actually said that they were able to identify an antiviral therapy beneficial in the treatment of COVID-19. Which, going through the initial question, the main question, the outcome, I think it was clear from the outcome that they were able to identify that it was beneficial. Overall findings were consistent with the findings of the preliminary report. So initially, that a 10-day course of Remdesivir was superior to placebo in the treatment of hospitalized patients with COVID-19. Yeah. So the final findings from this research was also in keeping with that. And also that data also suggested that treatment with Remdesivir may have prevented the progression to more severe respiratory disease. Initially, yeah, very less number of patients had serious adverse events, those on Remdesivir compared to the placebo group. Yeah, so the data from the research showed that if it was reduced, if this patient were given Remdesivir, then there was less progression to severe respiratory disease. So these findings, which I think is quite good as part of their conclusion, was that it suggests that treatment with Remdesivir may not only reduce the disease burden, but may also decrease the use of scarce health-related resources during this pandemic, which is very, very important. Because those on the Remdesivir group, if you recall, in the main questions, they had they had shorter recovery time, less use of supplemental oxygen, less tendency to develop severe respiratory disease. Yeah. Another thing you should also look out for in the paper is that definitely, except that is the first study that has been done, have they compared their trial with other trials? Because if there's been other work that's been done in particular subjects and you don't sort of compare it, are you trying to say, oh, yours is the final, or yours is the best, or yours should be followed 100%? But the good thing about this paper, yeah, they've stated their findings in relation to other trials. So if we check page 1823, yeah, they've actually stated what I've actually highlighted this one, saying there's a recently published trial on Remdesivir by Wong et al. But this, compared to this paper, which is a double-blinded randomized control, this was an open label randomized study. So if you remember, open label, that means you're just telling the patient, okay, this is Remdesivir, this is placebo, choose one. And of course, most people might want to go for Remdesivir, saying, oh, if there's a drug that I think will help me, then I go for this. So what that paper discovered was that 83% of those, they were not receiving oxygen at baseline. Now, the patient who received Remdesivir for 5 days had higher odds of clinical improvement than those receiving standard care. This benefit was not seen with the 10-day course. The major difference is because number one, the methodology of the study is different, and this patient in this particular one of this Wong et al. Paper that has been highlighted, and majority of them were not requiring oxygen as baseline, which will also go in contrast with this particular paper in which severe disease is also defined as those requiring supplemental oxygen. However, yeah, this is what they've said, this study was larger, blinded, and fully enrolled. So the major difference, because this is an open label and the one we're talking about is a double-blinded, so there's definitely going to be huge differences. Okay. I'll come to the questions much later. Now some drawbacks they've highlighted, which is something also we need to look out for in any paper. Have they been able to state any drawbacks? Now, when you even look at the drawbacks, are they drawbacks that we think will impact on the results they got? If the drawbacks has been taken care of, would it have led to better results? In this particular paper, they've actually mentioned that little was known about the natural clinical cause of COVID-19 when the trial was designed in February 2020, which is true. And considering, the methodology, the result, I would say is quite commendable that they've gotten this. The trial also was implemented during a time of restricted travel, staff illnesses. Many sites did not have adequate supplies of people. I can understand I've spent up to 1 hour. I'll just try. I'm almost through now. So other question, I think this forms part of the post-discussion questions, if I'm right. Yeah, I think that's part of the post-discussion question. So basically, there's an addendum about sample size determination that's following discussion on the groups. But I would like to just address the questions that has been sent on time. So the questions. So the first one. How does blinding the statistician in triple blinding reduce bias more than the double blinding? Now, the triple blinding, that means the patient, the participant, the researcher, the statistician. Okay, I said you would like to answer this question live. Okay. Okay, it's been answered live. I'm not sure. Okay. How does blinding? Yeah. Now, in terms of a research trial, especially, I would think going for a triple blinding is more like extreme, because if the statistician, the person collating the data, ideally you've already introduced either the control or the placebo, and the statistician, you're supposed to collate the data, and if you are now blind the person, I think in a long-term perspective, considering that this is even like a new drug or a new trial or intervention, it will be to the extreme, and it's going to even affect the result. Because at that point, I don't think you can even introducing bias in a normal setting is going to affect the result, except if it's a condition where you think some people, for instance, if the statistician has an ulterior motive in the drug or in the pharmaceutical company creating the drug, and you think, okay, all the statisticians should be blinded so that it does not affect the result, then you can be blinded. But otherwise, if it's like an independent person doing the statistics, then I don't think triple blinding will be necessary. The next question, does this mean chloroquine or glucocorticoid has an addictive effect from this study? The part that was highlighted in this study was that they found that the use of glucocorticoid, for instance, in treatment of COVID-19 in the UK, we use dexamethasone like as an anti-inflammatory, basically, or hydroxychloroquine as an addictive effect. They found that the use of this with Remdesivir was beneficial in terms of reducing the progression to severe disease, like earlier recovery to time, which either you use it in combination with Remdesivir or not. Remdesivir itself from the paper was shown to help with earlier recovery and like shorter recovery or shorter progression to severe disease. I hope I've answered the question. What if intention to treat wasn't used here? With the result change at all? Is going to change a lot, because intention to treat, when under the sample size determination, you need to be able to define the intention to treat. Intention to treat, that's the number of people, like the number of trials you need to do to even be able to treat one person. So what are the number of participants that has been involved in order to be able to say based on this result, I've been able to treat one person, is going to really, really affect you. Before you basically do any research or try, you should be able to say, this is intentional to treat population, I would say. So the other question, the excluded participants or dropouts, do we consider participants who do not participate in the study? Let's see. Do we consider other participants who did not participate in this study? Initially, they've actually tried to remove those that participated and those that did not participate. So after those that were randomized, they were able to state, oh, these were the dropout. And from their final results, they didn't include the dropouts, because if you're including the dropouts in the result, it's going to really affect, oh, this is my finding, this is my results. Yeah. I'm just a bit curious with the safety outcome. Adverse effects were also mentioned for the placebo, which I believe was normal. How did they determine what the actual cause of death was if none was due to Remdesivir, but people still died in Remdesivir group? Normally, okay, I said earlier that usually, if there's even any deaths, for instance, in this type of trial, they stated specifically that there was an independent investigator that was able to determine it was not due to Remdesivir, because they actually stated, oh, these were the adverse events they had, and how serious the events were, and it was specifically stated acute respiratory failure was the serious adverse event, like those requiring non-invasive ventilation and even those requiring intubation. So based on this paper, I'll go with what they've written, that they were able to determine that the cause of death was not due to Remdesivir, based on the findings from the independent investigators. It's just similar to that, for instance, if a patient is admitted and patient dies within 24 hours or patient dies after surgery, there's a full inquiry that goes into it, a lot of inquiry, investigations, everything, before they can say, okay, we think this death was due to negligence, this death was due to delayed a patient not being seen on time or not. So based on this paper, yeah, based on the findings from independent investigators, they were able to determine that those deaths in the Remdesivir group was not due to that. Okay, how do you reconcile, let me see, I've not jumped in the question. Can we actually say that the respiratory failure is as a result of the Remdesivir placebo, since COVID-19 itself can cause same? Now, going through this paper, although they've said there's some acute respiratory event that happened in the patients, in some of the patients that had Remdesivir, based on what they've written, based on their outcome and based on the use of Remdesivir, in day-to-day practice, COVID-19 itself will even cause respiratory failure, COVID-19 even causes respiratory failure, rather than Remdesivir. And part of the benefit of Remdesivir is to shorter time of recovery, to reduce the need for supplemental oxygen. So in itself, part of the natural cause of COVID-19 will be respiratory failure. And now considering that you have higher amounts of respiratory failure in the placebo group than the Remdesivir group, so that will make you to think that from this paper, that Remdesivir has actually reduced the natural progression of COVID-19 to respiratory failure, if you understand what I'm trying to say. Yeah. Okay. I'm a bit curious about safety outcome. Adverse events were also reported for the placebo, which I believe was normal saline. How did they measure this, since normal saline is supposed to be physiologic? Now, in terms of determining the adverse events, the specific ones mentioned was respiratory failure, according to this paper. those that require non-invasive ventilation, and those that required high flow oxygen and even endotracheal intubation. So I think based on these parameters from this paper, they were able to say that these were the adverse effects that were reported for the placebo. Now, if they're on placebo, you would think normally then that's the natural progression of the COVID-19 since they're not on remdesivir, or do they have other comorbidities? So from this paper, yeah, I would say those that had the placebo, which was normal, just normal saline, they had higher incidence of respiratory failure or adverse events, which I think will be attributable to the natural progression of COVID-19. Let's see. Following the opening of borders, are there plans to upgrade this research to involve a larger population, including Africa? I would say like now, okay, since, let me say, since August to December, I was on the respiratory COVID ward, and now I'm on ICU. We, as part of the recovery trial, like for instance, in the United Kingdom, there's this large-scale recovery trial where, so they randomized patients based on aspirin, azithromycin. We randomized patients based on plasma. Now, my trust, this last weekend, so trust like the hospital I work, they've released the report saying since August when we've been using plasma, so they pull plasma from COVID-19 patients that have recovered from the disease to see it will help in finding. So they released the report saying, unfortunately, they listed all the statistics that we've not found that the plasma has been effective, so we are stopping this. This was just last week. The other thing they randomized for is tocilizumab, which is a monoclonal antibody. Now, remdesivir, the guideline even in the United Kingdom, I think following this preliminary report, is that once a patient comes to hospital, they are COVID-19 positive patient, once they are requiring supplemental oxygen, even just nasal cannula 2 liters, we start them on remdesivir. And once it's also within 10 days, so there are a lot of guidelines. I think each country has adapted based following this research that remdesivir was useful. Now, to involve Africa, I think it will be based on doctors in Africa. It will be based on researchers in Africa, because we are the only ones that can do it for ourselves. Like, for instance, it will be difficult for them to come. Oh, they're coming from the United States to conduct this trial for you. They can do, but I think the main work has to be done by whoever, or the organization, the health system, like Ministry of Health or something like that. Yeah, because it's a lot of work. I tell you, once a patient comes and we want to randomize them, like it's even so stressful for us doctors. Like we have research nurses that actually come, they get the form, but as the doctors, there are a lot of checklists you have to do, like almost 2 pages, the blood samples, everything. Like it's even so stressful. Like we're like, okay, it's even additional work for us. Like why are we doing so? It takes a lot of commitment. It takes a lot of, like, there must be accountability and people must be ready to do the work. So for Africa, I think it will be based on, yeah, we Africans to do that. And why didn't they give disclosure directly in the paper? Does this reduce the quality of the paper? From what I know, like, patient confidentiality, like they take it like top notch, like to even release the name that, oh, this were the people involved and all that. But patient confidentiality is actually quite key. I think that is why they've not disclosed it. And I don't think it affects the quality of the paper in any way. Yeah, for the funding, if they disclose where the funding is from, I don't think it's going to really say is going to change the results the paper has gotten or not. Especially with COVID-19, there's been a lot of both independent and organization funding going towards treatment, going towards getting new drugs, pharmacological companies, pharmaceutical companies. A lot of, for instance, in the United States, there might be a political drive towards approving this drug or not. So I would say for them to have decided about the funding is just okay, because COVID-19 is something new and everyone is trying to you know, just get something. So yeah, not mention the funding is okay. And even if the funding has been mentioned, I don't think it would have changed anything really. Let's see.
Yes, I think that's all for the questions.
Okay.
And I want to thank you for the wonderful presentation. One thing that I am taking away from this presentation is that we don't just grab an article and just go to the results or discussion and just be reading about, or once we finish reading, that's what most physicians do. Once you finish reading abstract, you think you are done with that particular paper. But from what Dr. Leah Ajayi has told us tonight, you have to actually read critically, and that's the reason why the word critical came in. You have to critically check that particular paper in total, the way Nigerians will call it, in and out, and make sure that everything is right before you start implementing whatever the paper has suggested or recommended for your practice. I want to once again thank you. The soft copy of the presentation will be made available. This discussion is also being recorded, and I want to advise that we can also take time again and listen to this recording with the paper in your hand, with that article. I can tell you it's going to flow very well. Once again, I want to appreciate Dr. Leah Ajayi for this wonderful presentation.